I'd like to give a warm welcome to our speaker for today, Dr. Jonathan Colasanti. Dr. Colasanti is an assistant professor of medicine in the Division of Infectious Diseases and of Global Health at Emory University in Atlanta, Georgia. He completed medical school and a master's in public health at the University of Miami. He completed his internal medicine and global health residency at the University of Miami and his infectious diseases fellowship at Emory University. Dr. Colasanti developed a passion for HIV in high school and has dedicated himself to the field ever since. He has experience treating people with HIV in Miami, Atlanta, Peru, Nicaragua, and Ethiopia, giving him a global perspective on HIV treatment and care. His clinical and research interests focus on the delivery of HIV care to vulnerable populations across the spectrum of the HIV care continuum. In his research, he seeks to bridge the implementation gap in order to improve the delivery of HIV care by addressing socio-behavioral, biomedical, and systems-level barriers. In addition to his Atlanta-based work, he serves on the U.S. Advisory Board for a Nicaraguan NGO that strives to improve the delivery of primary health care in Nicaragua through a community health worker model. So Dr. Colasanti, I'll hand it over to you.
Great. Pardon me. Thank you, Sal. I very much appreciate the introduction. And I'm really thrilled to be here today to talk to the CTEC folks about ART Rapid Start, also referred to as Rapid ART, Rapid Entry, Rapid Initiation of Care, but essentially all meaning trying to get that point of offering antiretroviral therapy as close to the diagnosis of HIV as possible. I have, I think, a reasonable number of slides that we can get through, as leaving plenty of time for questions. And this certainly can be as interactive as you folks would like it to be. If you type in questions, I think the organizers will kind of push those forward to me, and if appropriate, I'll try to just stop and address those as we go along. And so I will jump in and wait for questions as they come. My disclosures, I do get some CME support from Integritas and Vindico, two CME companies. The objectives today are really as follows. I'd like to describe to you all the data pertaining to Rapid ART Start and really focus on the programs in the Southeast, as I think that hopefully will be most relevant to your clinical practice. I really want to advocate for Rapid Start approach in the context of equity. I think the more I've thought about this concept, and I've been thinking about it for a long time and been doing it for a while, I think there are some interesting questions to answer with research. But at the end of the day, I think this is really about trying to level the playing field. I'd like to review a few clinical considerations when initiating Rapid ART. I briefly reviewed kind of the makeup of the group, and I recognize that this is largely a non-clinical audience, and I hope that the presentation is really pertaining to all. That's what it is intended to be, though there will be a few slides that focus more on the clinical end. And then finally, identify some potential hurdles to implementation of Rapid Start programs, because I do recognize it doesn't come without its challenges, and that's part of hopefully what we can discuss today. So just to put this all in context of, I think, where we are now in 2020 with HIV in the US, I'm sure I'm preaching to the choir, and I imagine everybody's aware of the Ending the HIV Epidemic initiative that kind of launched after the 2019 State of the Union address, and with the goal of really reducing new HIV infections by 75% in 5 years and by 90% in 10 years. And I think to some of us on the front lines, that sounds pretty daunting, but I think it's important to have goals, and it's important that the federal supporters at the highest levels are really recognizing the need to really put resources where they are needed to try to get this done. And I highlight the 5 pillars here that they've put forth in the Ending the HIV Epidemic in terms of diagnosing people, treating people with HIV rapidly, and that's kind of specifically called out, obviously with the goal of achieving and sustaining viral suppression. And there are others to protect with the prevention means we have, namely PrEP, responding to clusters, and the HIV workforce, which I'm not going to get into necessarily today, but I think that's actually a very important part of this rapid initiative conversation as well. It's clear that We have close to half of patients with HIV in the US probably aren't kind of retained optimally in care. And if we're ever are able to achieve that, we're certainly going to need a stronger and broader workforce. I'll just review a little bit of the high level kind of HIV epi and where we are with the ending the epidemic. The federal dollars that are allotted to help achieve this goal are really trying to be dispersed to the 48 counties and a handful of rural states where the vast majority of new infections are occurring. And those counties are highlighted here in dark purple. And you can see that the South really makes up 48% of the counties that are being funded through this opportunity, and 5 of 7 of the states that are recognized as states with a more rural epidemic are also located in the South. So we are kind of right in the center of where this is all taking place. Um, this is certainly happening in the context, kind of in the bed of probably the most challenging social determinants of health as well in the country, or at least some of the most challenging. And these slides from AIDS View kind of highlight that. So among those counties where dollars are being sent, over 2/3 of the people are living at a higher level of poverty than the national average. And similarly, close to 3/4 of those counties have uninsurance levels that are higher than the national average. So people that clearly are going to have challenges with accessing care. And I don't think we can talk about kind of any of this effort to end HIV in the South without at least bringing up, and this certainly doesn't do it justice, but the context that we're operating in and the issues of structural racism. You see this map of slavery expansion, and it essentially mirrors all those maps we are so familiar with where the largest burdens of HIV are carried in this country. And I think I just recently kind of was made aware of the story of Robert Rayford, and I mention it so that you all can read further if you're not familiar. But essentially, it was a case of a young African American man in Missouri who had never left the state, and as early as 1968, it clinically certainly looked like he had a sorry, I saw an unstable internet connection, so I hope I'm still with you guys. But he had a clinical syndrome very, very compatible with what we would consider AIDS, and it's just kind of I think the gravity of what he lived through and the lack of how we hear his story today is again just illustrative of the landscape we're operating in. So back to kind of rapid start and what I'm really here to talk to you all about today. I think we're really excited, those of us who do this, that really all of our major guideline sources that I think we look to as US-based providers now endorse rapid entry in some way, shape, or form. The DHHS guidelines just recently in December gave this a grade A2 recommendation that ART should be started immediately or as soon as possible after diagnosis. The IAS has kind of endorsed this for about a year now. The WHO for a couple of years that really ART should be started wherever feasible on the same day as diagnosis. And the New York State Department of Health gives, again, a very strong endorsement to offer antiretroviral therapy, preferably on the same day, but if not, at least kind of within the first few days of after diagnosis. And so we talk a lot now about rapid entry and rapid ART approaches, really in the context of U equals U, and again putting this discussion of rapid entry very much in the context of equity, and as a step at least to try to overcome some of the incredible social determinants of health that people who are being diagnosed with HIV are living with. And I think we all have seen, hopefully, in our clinical contexts, what the campaign of U equals U and what those data really mean to patients living with HIV. But I think thinking in the context of rapid, yes, it's for that individual, but also for the for the communities with in which our patients live. And so thinking about some of these lifetime risks of HIV infection for those living with HIV, what this really ultimately often boils down to is the communities with which people live and where sexual networks come from. And so, equipped with the knowledge of U equals U, again, I think it's imperative that we bring antiretrovirals to those living with HIV as soon as they possibly can after that point of diagnosis. Before diving into the data, I always like to remind those who are kind of beginning to think about rapid entry and evaluating the data and the body of data that's out there. I do think it's important that we interpret the outcomes of some of these rapid entry studies in the context of where they're taking place. And I say that because on the left, you see the 90-90-90 targets kind of in a global sense. And this is data just recently published in AIDS at the end of last year, showing that about 80% are diagnosed on treatment and virally suppressed. And so their gap really is largely in getting folks diagnosed and kind of linked into care. Whereas I think, as you're familiar, and this isn't a perfect transposition because we measure our outcomes a little bit differently than the 90-90-90 outcomes, but if we think of retention and care as our on treatment, we that's really where our gap is. And so the question of, is rapid entry really set up to fix that particular gap? I don't know. I don't know the answer to that yet. I think there's literature that's kind of trying to answer that. But I think kind of focusing in on really that initial linkage to care and getting people plugged in is where this intervention really sits. So I'll at least share with you some of um, the global data, largely because that's where our randomized trial data comes from. And so I just want you to be aware that it's there. But again, interpret it in context. This is from a systematic review and meta-analysis done by Ford and colleagues that looks at kind of 3 to 5 studies, depending on which of these outcomes, and shows you the forest plot here. So in terms of getting people on ART within 90 days, that intervention clearly seems to do this in all of these settings. This particular study, Labhart and colleagues, I believe this was done in Lesotho, and this was truly bringing treatment to the point of the community where they were testing and treating in people's homes, and bringing antiretroviral into the community rather than kind of waiting on the patient to come to clinic. So, not surprisingly, really truncated that ART start. In terms of keeping people in care in the kind of at least the short run of the long run, in terms of 1 year of follow up, there's some nudge towards this may be beneficial in doing that. And similarly, it looked to have a beneficial impact on viral suppression at 12 months as well in these settings. Whereas those that were kind of overall lost to follow up and died, you can see they both kind of cross one there. So neither are statistically significant. And the numbers, as you can see with the confidence intervals in the individual studies, are pretty small. So I think it's hard to make much comment around that at this point. But now I'll turn to the US. In 2013, they piloted this model, starting very small. They started with um, acute infections, and then kind of expanded to those that had opportunistic infections. Um, and this was in the context of already trying to start antiretroviral therapy for all. It was a little bit before the guidelines recommended that, but they were already doing that, but not necessarily on the same day. And what you see here in these kind of colorful boxes along the top row are what we all know our patients kind of have to go through at the point of diagnosis and then finally to get into care, um, in terms of a lot of paperwork with insurance and registering and housing and et cetera, getting labs done, getting an actual clinical evaluation, meeting whatever potential ART criteria a jurisdiction or clinic may have, and then starting antiretrovirals and finally achieving viral suppression. And you can see with their nice graphic, they just kind of tried to truncate that and say, we're going to do all of these things that we know are important at the point of diagnosis, wherever possible, literally walking patients from diagnosis, oftentimes at the hospital, over to the clinic, and offering antiretroviral therapy, as well as completing the other necessary um, parts of enrollment into care. Okay, so I see a couple of questions. Um, There was a question about the slide I showed a couple slides ago in terms of the on treatment and retained in care, and in the difference between the global and the domestic setting. And it's just kind of how the care continuum are measured in our respective settings. And so, yeah, I recognize they're not equivalent necessarily, but it's kind of the best metric we have to compare. And then someone else said, brought up in terms of counseling around risk reduction behaviors. And certainly, yes, this kind of, this does not, this is a paradigm shift in a way, but it certainly does not um, say that any of the prior kind of education and counseling we would give to our patients is no longer necessary. It's more to say that many of those things shouldn't serve as a barrier to initiate an antiretroviral therapy, and recognizing that, you know, the data are incredibly clear, that really one of the best prevention mechanisms is getting individuals undetectable, and so we should assist with that as quickly as we can. This walks through the kind of the initial uptake of the rapid program in San Francisco. You can see on the left this bar graph here, that along the x-axis is time, kind of 0 days, 1 day, 7 days, and 30 days, and then proportion of individuals who are on antiretroviral therapy. And you can see the vast majority accepted on that initial day. 95% were on it after 1 day, and by 30 days, certainly everybody was on therapy, compared to their quote unquote universal arm, which was their comparator group. And again, these were people that were not being withheld antiretroviral therapy because of a CD4 threshold, but more just because of the way the system was structured. And by 30 days, only 2/3 of those individuals were on therapy. And I show some key sociodemographics from their original study over to the right, largely because I think a lot of us that practice in the Southeast, when we hear about HIV in San Francisco and New York, we kind of think of them as public health meccas, and just operating in a system that's so much more supportive of some progressive public health initiatives. But indeed, their population still largely lives with with high levels of social determinants of health. So a quarter of their population was homeless, and everybody was uninsured, and high rates of substance use in that population. I'm not showing you all of their data, but now to kind of illustratively show that after they did the pilot at the San Francisco General Program in 2013, they rapidly scaled this up throughout their jurisdiction of the Department of Health. And this looks at their kind of initial cohort of individuals. I think it was about 250 folks who were started on rapid therapy through the Department of Health, kind of in those early years, and showing that you can see here with the curve, kind of the median time to becoming undetectable was very short, under a couple of months, and 96% had achieved viral suppression after 1 year, and 91% of them had maintained it at 3 years. So kind of at least some very nice cohort data to say folks that kind of go down this pathway generally do well. They do just fine. But now I'll shift, before I shift to my program, I'll check the questions. Um, and back to the San Francisco diagram I saw, there's a question here about, was the first clinic visit not necessarily with an MD, PA, or NP? In their particular setting, I do believe that the first clinic visit was with as it's kind of written, usually with someone that has a prescribing ability for antiretroviral therapy. And so it is generally with one of those professionals, although there may be models kind of moving even broader than that. So I'll turn now to some programs in the South. I'll start with the program that I work at, which is the Grady Infectious Disease Program, sometimes referred to as the Ponce Center. And just to give you a sense about the clinic population we serve, first of all, our funding, we're essentially 100% Ryan White funded. We get Part A, B, C, D funding, and some state AIDS money as well, but again, largely grant funded. And in terms of our patient population, we do have about 28% women, largely an African American population, with a small minority of Latinos. You see by our age breakdown that our median age is kind of around the age of 45, which is a little bit young for a lot of US based clinics. So still have a very large proportion of our population coming in as young individuals, while also kind of dealing with the aging population and the challenges that come with that. About 2/3 of our population lives at less than 2 times the federal poverty limit, and our patients are largely uninsured, with kind of a quarter each getting a public insurance program, very few privately insured patients. And by virtue of how our clinic kind of was originally set up, and again, that's a whole nother discussion, um, a large proportion of our population have progressed to AIDS and at least carry an AIDS diagnosis. And so a lot of late stage disease. And just of note, we are operating in the context of being a non expansion state in terms of Medicaid, because that is relevant for this discussion. So we entitled our program REACH, or Rapid Entry and ART in Clinic for HIV. And really with the goals in this program, that the patient would have a clinician visit and antiretroviral access within 72 hours of first kind of coming to our clinic. A lot of patients enter our clinic as kind of just like a walk-in referral. And so trying to take care of them that day, or if a patient was diagnosed in the hospital or within our Grady system, trying to get them over to clinic that day and with through the system kind of within 72 hours. And then and we certainly had a goal around decreasing time to viral suppression for these individuals. We don't have to go through this table comprehensively at the moment, but really what this represents is all of the changes kind of on the left that we had to make, and the level of the health system that this had to be done in order to even think about doing rapid start in our clinical setting. And so from the level of our funders at Ryan White, to our kind of Grady level hospital system, and then our more specific clinic level administration, to clinicians, this really was a practice change for our clinicians, and pharmacy. Pharmacy, we have an in-house pharmacy, and our pharmacy team plays a large role in helping patients gain access to medication. So they were a large part of this, as well as our nursing. And then front office with scheduling was a huge task to kind of revamp that. In terms of our data that I'll show you, we looked at a cohort of individuals that enrolled in our clinic from January to July 31st, 2016. And the pre-reach group, so kind of before we did the intervention, took place from January to mid-May, and then from mid-May to late July, we piloted this rapid entry intervention. And you can see kind of, I think, just to impress upon you the volume that we deal with, and it's one of our biggest challenges really with this intervention, is how to appropriately scale it. So we had 140 patients newly coming into the clinic in just really a 6 weeks time period that we were doing this. I will say where our program differs from many is we were really trying to do this for both patients that were new to HIV care and naive to antiretroviral therapy, and those kind of coming back into care. So that's a different group, I recognize, and one that we made a decision clinically that we wanted to do. But a lot of programs are really just focusing on new diagnoses at the moment. In terms of how we analyze them, you can see that patients who were virally suppressed when they came into the program were obviously excluded. And a lot of patients had been in the hospital and were actually started on antiretrovirals in the hospital, so we didn't include those. And then a handful of other reasons that patients were excluded because they essentially didn't have appropriate follow-up. And you can see our combined cohort characteristics here that largely mirror the overarching clinic characteristics that I already showed you. So this isn't a young age group in this cohort, about a median age of 35, 90% African American and 80% male in this instance, a large proportion uninsured, a large proportion unstably housed. We've had some particular challenges around housing in Atlanta recently. You can see the median income under $9,000. And again, a large proportion with substance use disorders, or at least active substance use, not necessarily disordered use, mental health diagnoses, and a low CD4 count. So this is also very relevant, I think, as you think in your individual context of starting these types of programs. Our median CD4 count at our clinic is 146 at the point of entry, which is lower than any of the other cohorts I've seen published, including those in Africa. I mean, most of these studies, in the African context, in fact, patients with late stage disease were often excluded um, uh, from these trials. And you can see that 40% of our folks actually did come in ART experience. So these were restarts. A lot of people ask about what antiretrovirals were used. And these are just kind of the raw data showing what antiretrovirals were prescribed kind of outside of the rapid initiation context in the left column, and then within that context in the right column. And really just, I think, reflects what the prescribing at the time was. There were some folks getting abacavir, which is not a drug that you would typically start in a rapid start setting, and they were getting that because those were restarts. They weren't new starts. Um, and you can see patients were largely getting integrase inhibitors in this cohort, with kind of darunavir being the second most. And these are kind of broad strokes of our results. So on the left-hand side, you see a table really with each of the rows kind of represents a process improvement step. So days to the first scheduled provider visit went from 2 weeks down to 3 days. Attended provider visit, kind of similar. Days to antiretroviral start from 22 days down to 4 days. And then what I think is important to kind of be transparent about with our results is that the attendance of that first visit, and kind of achieving viral suppression as a whole. Neither of those improved statistically in this particular cohort. And there's plenty of reasons behind that, I think, that we can talk about. But the point being that through this process improvement, largely what we saw was the days to viral suppression decreased from about 77 days down to 57 days. So kind of, and this was in a non-controlled setting, so viral loads, follow-up viral loads were just ordered when patients came back to clinic. But even still, seemingly a 3-week gain in terms of becoming undetectable, we hope would have some impact at that community level in terms of U equals U. Looking at our results a little bit more granularly. So we recognize that people that kind of present to care soon after diagnosis may be a little bit different in some ways than folks that present a little bit later. And so this is just to show you that we're cognizant of that in our group here. And this was a very heterogeneous population in terms of how they entered care. And you can see that achieving viral suppression in the early group, regardless of whether it was pre-reach or post-reach, was high, was 86%. And it was much lower in those presenting later to care. Kind of, again, regardless of whether this had to do with rapid or not. And so probably representing a difference in those populations, and probably a difference in their needs for their model of care that will ultimately benefit them. Similarly, these were some post hoc analyses we ran to just kind of try to sort through some of this a bit more. And so looking at this top table looks at time to viral suppression and the hazard ratio kind of based on what group people were. And certainly even in a multivariable analysis, the post reach group, so the rapid entry group, still certainly made gains in viral suppression. But being ART naive was also a driver. So again, those people that were kind of probably newly diagnosed, we didn't have a perfect measure of newly diagnosed in this. So kind of, if that's a marker for newly diagnosed, that seemed to play a role. And then looking at the achievement of viral suppression similarly, whether or not it was rapid entry, really did not seem to play as much of a role. And it was more so the people that were newer to care were more likely to achieve viral suppression. And this is just an illustrative example. Take this with a huge grain of salt. This is very rough programmatic data. For our pilot program, we ran it kind of for about 3 to 6 months initially, and then it really just became overwhelmed with volume. We didn't have dedicating staff for it. And with our subsequent Ryan White grant, we were able to get dedicated funding for rapid entry. So we do have a full-fledged program that kind of relaunched early in 2018, and you can see the numbers. So I mean, just since March 2018 through September 2019, these are kind of close to 900 patients coming through our clinic for enrollment, and close to 500 of those were at least shuttled down the rapid entry pathway. These don't really represent outcomes at all. So before I move on to Crescent Care program, I will try to take a minute to look at these questions. So a question about, are there clinical concerns regarding starting antiretrovirals rapidly? And we will talk about that. So there certainly are some, and I want to get into that a bit more, and we can converse around that as appropriate. Um, some of the elaborate more of the challenges of scaling. I can do that. And someone just kind of seconding that they like the including those re-entering care. So in terms of the challenges with regard to scale, can we go back? It's mainly volume. I mean, so I think about, so our clinic, I don't know if I said initially, has 6,200 patients. And I think, like many clinics that are just essentially all grant funded, we're kind of grossly understaffed, and our frontline folks just struggle with the volume. So whereas a lot of clinics may see a new diagnosis every week or so, I mean, they're seeing a new diagnosis a day, if not multiple new diagnoses a day. And this process, which we'll go through a little bit more towards the end, there are numerous steps to it. I mean, this isn't a short day for patients. Most of these programs will say, this is a 3 to 4 hour process for the patient to get on clinician schedules. I think in a busier clinical environment is a little bit more challenging. I know a lot of these programs kind of rely on a true clinical champion, and like someone that can be on call essentially to just drop in and see one of these patients in smaller volume programs. Whereas in a program like ours, we really have to build it into the schedules, and sometimes ask our providers to kind of go above and beyond, which again, I think is a whole nother discussion in terms of workforce and burnout, which is a very real thing. And we have to balance. And we know that our providers need to provide care for the long term for our folks. So those are some of the challenges, and I'd be happy to talk offline more about that. So turning attention to Crescent Care, this was another rapid start initiative that was done in New Orleans. Crescent Care, just as background, they were an FQHC that actually originally started as an AIDS service organization. They have kind of robust support services available. They have mental health and substance use services. They have case management. They have a lot that kind of goes along with this, and this is done within the context of Medicaid expansion, which did happen in Louisiana. And so you're kind of aware of the groups we're looking at here for comparison's sake. They're kind of CCSI. This was their rapid start. They were kind of included in this group based on being seen by a provider within 72 hours and given antiretroviral therapy, compared to their early intervention services group. So this was their group who was getting Ryan White early intervention services. And kind of clinically, we're using the same protocol, but they just so happen to not get into the clinic within 72 hours. So comparing a group that may inherently be a little bit different. What they did at their medical provider visit, they gave some brief education around HIV life cycle, the importance of adherence. They talked about U equals U. They assessed their comorbidities. They did a targeted physical exam. And they kind of had a single regimen that they were really using in this context, at least, that was recommended by medical leadership and kind of pre-approved, so to speak, to be used in a setting where you're not going to have some of your lab values back as you're making that clinical decision. This decision, and we did this the same in our clinic, was left at the hands of the clinician and the patient. Although this was kind of a clinic-wide initiative, nobody's hand was forced, and we really, I think a lot of us that do this still strongly believe in the therapeutic relationship between the clinician and the patient, and value that, and leave that to that decision making. They used a directly observed therapy of their first dose. So they actually, the clinician was there with the patient as they swallowed the pill in their exam room. San Francisco did this as well. We don't do this in our clinic. We can't operationalize that, but the clinicians that do this just speak to kind of how powerful this has been, I think, both for patient and clinician. Um, they, after their clinician visit, they enroll them in whatever insurance program they need. They make sure to get those initial baseline labs and connect them to whatever social services that the patient would need. And their analysis looked at kind of those that were enrolled in clinic from December through early 2018 and had at least 6 months. So we have some follow-up data. 4 of their rapid start group was lost to follow-up, and so they weren't included in the analysis. And then a handful in the EIS group weren't included in the analysis either. You can see a comparison of their groups here, and that this was, again, a young cohort, 29 years old, about a quarter of the population, or 20% female, largely African American, with a higher proportion of Latinos than we have in our clinic cohort. And you can see a very high rate of concomitant STIs at entry to care, a large proportion living under the federal poverty limit, and a large proportion uninsured at the time of clinic entry. Importantly, another thing that did differ between their groups, which I think is important to interpreting results, is they had a larger proportion in the EIS arm that had mental health diagnoses, and there was a lower CD4 count in that EIS. So again, suggesting and kind of by virtue of how they got included in this group, a group of patients who came to care a bit later. These are some of the nitty gritty kind of details of their antiretrovirals and some of their clinical resistance data, because I think that'll probably be of interest to the clinicians on the call. In their rapid start group, all but 2 of their patients got the regimen that they had recommended. Most patients had genotypes performed. 20% had some baseline transmitted resistance. The bulk of that, as you would suspect, was NNRTI resistance. So when I get into the recommended regimens, that is kind of irrelevant because we're not going to be choosing NNRTIs. 3 patients did have an M184V, and a couple of those had been on PrEP. 4 patients had multiple PI mutations, and all the patients who did have transmitted drug resistance also achieved viral suppression. And interestingly, in their cohort, they didn't have to make any changes in their therapy due to renal or hepatic toxicity. And these were kind of similar to their comparator group. And these are what their data look like. So the rapid group is represented in the blue columns, the comparator group in the green columns. And you can see, I mean, linked is 100% because they had to be linked to be included in the analysis. Everybody was getting offered same-day ART. Really, the difference is how long was it from their diagnosis that they actually got into care. And then you can see there's a slight drop-off in viral suppression, a bigger drop-off in retention and care, and a viral load that is undetectable at close to a year follow-up. Again, it's probably something about that group that there's underlying challenges that are going to also make it hard for their ongoing care. And I think that's important, that rapid entry should not be seen as an intervention that replaces strong wraparound services and retention and care programs, because that really is a different animal. But I think what we can say confidently is the group that got into care quickly and on meds did really, really well. So kind of like the San Francisco data, the vast majority of individuals are remaining undetectable and in care. So I'll shift now to some of the barriers of implementation. Here's just a handful, and I'm sure people can list many, many more. But certainly just getting patients from the testing site to a treatment site can be a challenge. Some clinics have very complex eligibility criteria. That was certainly the case at our clinic, where patients had to largely have an age diagnosis or be in a certain age group, and kind of had to know their CD4 count before they could even get linked to care. There's, I think, for most clinics, some income and residency requirements that can hinder this. how to get access to meds without a payer source, never easy, and then getting folks on a clinician schedule. There were certainly barriers at the staff level, at the clinician level. We of course always hear that's how we've always done it, and my response is, well, look at where it's gotten us. I mean, obviously, I don't mean to belittle the incredible strides that have been made in HIV care and treatment over the last few decades, but we have incredible disparities that we hope making some of these changes can alleviate. Um, Not being comfortable working without labs. It's for a clinician that has practiced their whole career and in the US, and we're very used to making clinical decisions based on lab results. For years, we would never start someone on antiretroviral therapy without seeing a baseline genotype. But because of the data that are out there now, and because of the way the guidelines recommend things, it's okay to get these labs and review them as they come in, and potentially make some changes to initial regimens based on that. But it shouldn't necessarily prohibit the starting of the drug. In our clinic, um, we because of cost and availability considerations, we still use tuberculin skin tests and PPDs to screen for latent tuberculosis. And so often patients weren't allowed in our clinic until they had one of those completed. And so that was a barrier that in and of itself to getting patients into clinic. And many non-clinical staff, when we kind of lifted that and said that we can get them in care and do this at the same time, were pretty nervous. They thought this was going to put them at more risk for being exposed to TB. And so we had to do education around why that screening test is not necessarily protecting you from exposure to TB, et cetera. We weren't sure how patients' attitudes and beliefs would affect this, or their kind of biopsychosocial comorbidities that can make care delivery difficult. So this is an illustrative slide. I don't want you to get lost in the text of it, and I know that's a forbidden rule to not show a slide where I don't want you to see text, but really just focus on the colors. And apologies to those who may not be able to see colors well. But this was our enrollment process before we did this rapid entry. And the two green dots, so patient arrives and patient receives an appointment, that was just the point where they'd be told, this is when your first appointment will be. They had to go through all of these steps before they even got the appointment. And each of the red stop signs represents a point along the way where a patient would have been told, you need something else. You need to know your CD4 count. You need some document, X, Y, and Z. You need a PPD placed in red. Come back another day. And what we did, again, through lots of meetings and with various stakeholders and getting buy-in, is we got rid of, as you can see, all of those stop signs. So the goal was at least patient does not walk into this place without knowing when their appointment's going to be, if it's not going to be today. And hopefully it'll be in one of the next couple of days. The one thing that we added, and that we didn't really have during our pilot and made this a real challenge, but had once we got some more funding for this, was a peer navigator that was assigned to the patients when they first came into care who didn't have all of their paperwork. We were granted a 30-day grace period by Ryan White to kind of say you can work on getting all their documents together while you start the care process. This is an example from the San Francisco Department of Health, where they really do community-wide coordination with their HIV testing. So you have their testing sites represented on the left here. They had these rapid ART hubs, so a handful of clinical sites where patients could go to get rapidly started on antiretrovirals. And if they weren't going to stay at that site for their ongoing care, they would then be connected to more of a long-term care site, but these sites could get them on ARTs quickly. And in the center of that, you have this roving links coordinator, which is somebody who would work on linking patients to care and helping them overcome whatever hurdles were there that were preventing patients from doing that. A couple practical things in terms of how to get antiretrovirals in these situations. When someone doesn't have a payer source and they don't have their documentation to enroll in Ryan White right away, almost, I think all of the pharmaceutical companies at this point have patient assistance programs that will, you can get anywhere from 30 days to up to a year's worth of medications. So that can be done. Sometimes we have our patient navigators help out with that if patients aren't able to do it on their own. Some clinics use starter packs, and so pre-packed 5 to 7 days of meds that, again, you can give it to the patient at that point of care, while their paperwork gets processed and a real prescription is kind of processed. Um, there's ways to use Ryan White dollars if folks are just waiting on ADAP applications with stopgap medications. And of course, copay cards can help fill the gaps. And a critical piece, and something that does make this so much easier, is Medicaid expansion. And Dr. Halperin, that kind of champions this program down in New Orleans, really talks about their Medicaid expansion as a gift from the heavens when that happened, because it really kind of opened the floodgates in a way that allowed them to give patients medications, and cut down on the workarounds they had to find to get those medications. What to start? So, as you like all first line starts at this point, the recommendation is to avoid an NNRTI based regimen. The DHHS guidelines, in so many words, endorse the three of these regimens. So a bictegravir, TAF FTC regimen, a dolutegravir tenofovir regimen, or a boosted darunavir tenofovir regimen. Whereas the IAS guidelines, again, like their overarching first line recommendations, have really kind of shifted to all integrase, all second line integrase inhibitors, or newer generation integrase inhibitors, as they may be called. And a couple key facilitators that I think the folks of us that do this would endorse, and can also be some of our biggest challenges. So, making a way for same day appointments in the clinic, having a flexible provider schedule. Oftentimes, as I said, that may mean having an on-call backup provider, having some ART regimens that kind of, again, have medical leadership sign off, that may guide frontline clinicians, that they don't have to kind of do as much thought in terms of what am I going to start initially. That becomes much stickier if a patient has previously been on antiretrovirals, obviously. Having availability of starter packs can really facilitate this and expedite the process for the patient. Patient navigators have been written about with these programs that are kind of at least the anecdotal key to them. Having some sort of accelerated insurance enrollment process, observing the first dose in clinic. Again, I know programs that do this and programs that don't. The ones that do it absolutely love it. And you have to find a way to make sure that the patient's going to get ongoing antiretroviral therapy. I hate to have the barrier to starting antiretroviral therapy being we don't know how. I think systems need to be developed that we can make sure that patients get them. But starting patients on 30 days of a dolutegravir or bictegravir or boosted darunavir regimen, even if kind of the worst case scenario happens and they can't get ongoing therapy, is very, very unlikely to result in resistance. To be transparent, I am a proponent of this kind of clinical programming, as you might imagine, since I'm giving this talk. But I recognize the data are mixed. This is one paper that kind of calls into question: is it, are we starting too quickly? And I just wanted to go through the data because, again, I think a lot of these data are just really important how we interpret them. This was a French cohort. They looked back retrospectively over the last 20 years at their patients and when patients were initiated on antiretroviral therapy and at what CD4 count. And what they show is that those who were started earlier tended to not kind of get to viral suppression as well as those that were started a little later. But there's an important nuance here, I think. You can see that from the diagnosis to first visit here, and likewise to first start, they have them broken down by CD4 count. And it's really the earlier CD4 counts who are getting started earlier, because this is a historical cohort study. That's how things were done because that's how guidelines were written at those times. And what you see is now when you look at their results in terms of viral suppression after 6 months based on time to start, which is represented up here, Um, those who had longer times between diagnosis and when they started had higher 78, 79% viral suppression compared to those who were early starts. But again, I think these are important. I think it's important to ask which are the patients that are progressing to late stage disease. Again, I think there's oftentimes a multifactorial process that leads to that. What we can definitively say about rapid entry, I think with the data we have, are that people that get it do well with it. Whether or not it's a causal factor in improving long-term outcomes, I don't know. But I don't know how relevant that actually is to the discussion on whether we should be doing it. Similarly speaking, the Pop Art trial, which was a large community-wide trial looking at kind of immediate ART and linkage to care, a robust linkage to care, which was done in Arm A, versus just this kind of robust linkage to care and operating with ART starts based on country guidelines versus pure standard of care. Um, and what was seen, this is showing HIV infection, and so prevalence. Does HIV incidents go down in communities? Comparing this group A with group C, there's no change. Comparing group B to group C, there seems to be a change. And so this group really seemed to benefit. And so what I want to show is that some people will kind of use this study to say that immediate ART doesn't change the game, doesn't change community-wide transmission. But here's what happened to the people that were on therapy in groups A and B represented here. They achieved viral suppression. Time from diagnosis to ART went from 10 months down to 6 months in this Arm A, which was kind of intended to have immediate ART start. So this wasn't really immediate ART start. This truncated time to start, but it didn't kind of get to that same day approach. So I don't want, again, folks to hear these data and misinterpret them. I'll finish with kind of my point about equity. We have data that show us that African American men are more likely to have delays in ART initiation, even after seeing a prescribing provider. We can't have that be the case. I really don't think there's a better demonstration of our commitment to communities as clinicians than providing same day access as soon as we are able to see them. And as days on, a friend of mine who's the executive director at Sister Love and really a reproductive justice advocate, as she said to Dr. Halperin when he was talking about rapid entry, she kind of said, "Of course it makes sense. See my brothers and sisters as your own. If you do, then of course you will see patients same day, start same day, and love same day." And that's how Dr. Halper and I, who are both really strong advocates for this approach, feel and hope that we are doing by offering this to patients. Um, and I'll finish just by saying again that I don't see rapid entry as our solution to our retention and care challenges that we have here in the United States. But I think it's part of a broader package to improve the overall HIV and prevention continuum. It doesn't stand alone, but I think it's programming that we can integrate into our current programs as part of a package. And there's some really great guidance for clinicians. I hope that you'll have this PowerPoint as reference, but some more tangible things as well that the group from San Francisco, Sousa Coffey and her colleagues at the Department of Health in San Francisco put out that really outlines how you can do this in a clinic. And just a plug for this Rapid Start Consortium. Sorry, I know we're running short on time. That Dr. Halperin, myself, Adia Rana, and Danny Zvanig from out in Arizona, we all kind of just grassroots have been working on this in our own clinical sites and put this group together. You can see all of the cities that are represented. There's an email there at the bottom for Jeremiah, who's helping us with some of the admin of the group, thanks to UAB's CFAR. And again, it's a grassroots group that's coming together to really discuss best practices, work through logistical hurdles together, and hopefully also set up a platform for research and collaboration on that level. But as of right now, it's really largely a troubleshooting group for people. I see that there are a bunch of questions. I'm gonna stop talking now. So the clinical concerns. So Kate, this is to address Kate's question, and I actually I failed to put in one of the clinical sides I think I had intended to. Um, in patients that are being newly diagnosed with HIV, and in settings where those new diagnoses generally have very high CD4 counts. I think there are almost no kind of clinical challenges to doing this. The clinical concerns we do have are in settings like mine, where we see patients oftentimes presenting later to care, and they may have low CD4 counts at entry to care. Um, and that's where I think a slightly more detailed kind of clinical assessment, a thorough review of systems, and sometimes saying to the patient, we're going to wait on a couple labs before you swallow that first pill. Sometimes I give a prescription and just say, I'm going to call you in a day or two. Don't start it yet. Um, and in particular, I think thinking the clinical things to really make us hesitate to start antiretroviral therapy are cryptococcal meningitis and tuberculous meningitis and potentially pulmonary tuberculosis. Those, I think, data are evolving and that conversation is evolving, but those are really the main three clinical entities, I think, where a clinician would be hesitant. And so we certainly ask questions around that. If someone has a clinical syndrome that is compatible with cryptococcal meningitis, we're not starting antiretrovirals that day. Um, and and for us, we actually we recommend we do cryptococcal antigen screening for folks that do have low CD4 counts or are suspected of having low CD4 counts. So again, we'll get that cryptococcal antigen back within 24 hours. So sometimes we'll ask a patient to wait for that to come back before they start. But those are kind of the clinical things we think a lot about. There's certainly the issue of renal issues, and does someone have an acute kidney injury or even unknown chronic kidney disease. I think the clinical thought on that by and large is a couple days of medication in that setting is probably not going to do much harm. The key is following up those labs in a fairly short turnaround and being able to reach the patient and make changes as needed. I think from the clinical experience that we've seen in the published data, this has not been an issue clinically. The other major clinical thing to think about is hepatitis B. Um, and so because we don't have our hepatitis B serologies at the point we're starting these medications, you're always going to want to treat someone as though they do have hepatitis B. The regimens that I showed you are recommended are obviously in line with that. We're not using any abacavir-based regimens or any kind of reduction in NRTI number used in the regimen. And so those are the main, I think those are the main clinical concerns. Um, do we utilize the question, another good question, do you utilize any standard medication readiness or adherence assessments? To be quite honest, in my clinical setting, I wouldn't say we necessarily use a standard assessment of that. Those conversations are always had at multiple levels in our clinic. And we certainly try very hard to make this a partnership with the patient and not forcing anybody to start. I know some of the programs, Serena Koenig's program in Haiti, at least as part of their research program, did a readiness assessment. And I think a number of clinics do. I think you kind of would treat it however you do your usual clinical processes in your clinic, and certainly want to make sure the patient's on board. Question about having any perspective on scaling up outside of the context of programs that are bound to academic medical centers. Well, what I'll say is Crescent Care is actually a great example of that. They are not an academic affiliate. They are a federally qualified health center. And so they do both non-HIV and HIV care and have really developed a process within their system where patients are funneled through largely their non-kind of HIV program or an ID program, maybe seen in their STI program or just their general primary care. And they are often seen by a general PCP that's not an HIV expert to get that initial start, and then they're referred to their kind of in-house HIV expert. But I'm seeing a lot of programs doing this at the grassroots level, relationships developed between testing sites and those clinics, so that that bridge can really be built and get those patients over as quickly as possible. Now, there are certainly challenges to both settings. I'll say, I think outside of kind of the academic and large health system level, there's sometimes some nimbleness that can be had and programmatic development that's really helpful to this type of programming, that make it actually challenging in our settings. For people who re-enter care, do you do resistance testing, or does it not matter with the current regimens you're using? Is there anything you do differently for people who are re-entering versus people who are newly diagnosed? Okay, so a couple of questions there. The first one, is there anything you're doing differently for people re-entering versus those who are newly diagnosed? Within our clinic, we have lots of kind of social support programs and wraparound programs that we try to get folks linked to based on their need. And what I'll say that we're not doing as well as I would like to be doing is, I think re-entering care in and of itself is almost an early warning indicator, I think, of having challenges staying in care in the long run, unless someone had a very tangible reason and kind of was a one-time thing of why they may have fallen out of care. But what we see a lot of times is those who are kind of cycling in and out of care. And so I think it's really important that we spend time with those individuals, assessing what their needs are and match the programs that they're linked with their needs. But in terms of starting antiretroviral therapy, do we do anything differently? So obviously, more time is needed to kind of assess what their prior regimens were, assess how they were taking their prior regimens, and I think the question of, do we get resistance testing? It's certainly a case by case basis. We try to follow the guidelines and how they're written, and that a lot of times for patients who have been off of therapy for more than 4 weeks or so, we will, particularly if they don't give us a history of like horrific adherence toward the end of their last regimen, we oftentimes may restart that last regimen, with the most important thing is very quick follow-up labs, to make sure that their viral load is responding as we would hope and appropriately. And if not, sending resistance testing at that point, where you've put some selective pressure back on the virus so as to not just get a wild type and kind of be fooled by that in a way. But yes, there has to be a lot more attention and paid to that, and it's not easy. And I think and our clinicians who do this certainly have voiced that as well. Like the 23-year-old who has no medical comorbidities, and if they don't have any psychosocial comorbidities, then it can be super easy to start them on antiretroviral therapy. With someone who's been in and out of care, it can be a lot more challenging. But we still try to get them back on antiretrovirals if that's what they desire. I don't know if that addresses the question. Talk about the willingness of the patient to start treatment immediately while processing their newly diagnosed status. That's a great question, and one I think about a lot in doing this. And again, I think the importance of this is not to say that this is a blanket intervention and works for everybody. I do think we have to use our clinical gestalt and our emotional intelligence, and listening to our patients. And if the patients are just devastated and can't even wrap their mind around the diagnosis and are processing that, maybe starting medications isn't what they want right now, and that's okay. And I think it's important that we support them in that decision, and that even though we're recommending start, it's okay not to, and there are not probably any long-term harms that will come to them because of that decision. And I think this also has to do with individual programs and how programs are receiving patients in terms of where do their referrals come from. Dr. Halperin, who runs the Crescent Care program, their patients are largely kind of voluntarily tested. They're coming in saying they want to be screened for HIV, oftentimes not surprised by their diagnosis, and they're ready to kind of hit the ground running. Whereas a lot of the patients that we serve in our program have been blindsided by this in the emergency department, and their lives are shattered and they don't know what to do. And so, yeah, there are certainly patients that we will hold off, if it's the right thing to do for that individual. A question about progress and suggestion on peer patient navigators. Have we hired any patients who may have gone through this program to improve the process further? I don't believe that a patient who's gone through this particular program has been hired, though I can't say that 110%. And to be honest, we have not even done a comprehensive kind of assessment of the program and really gotten as much patient input as we would want in terms of the parts of the program that they would like to see improved. And so that's certainly on our radar of things to do. May have missed it as their follow up either by phone, text, social media, see how folks are doing with their new ERT. Yeah. So again, because I made this talk a little less clinical, I think I left that slide out. So this is asking about follow up with texts or phone calls or social media about how they're doing with their new antiretrovirals. Um, so this is one of those challenges of scale. So yes, certainly in our clinic protocols, there's a pathway that patients are supposed to get a phone call back kind of within 72 hours of starting to make sure they're tolerating the medications, et cetera. Um, I'm not foolish to think that this is one of our programmatic aspects as volume has kind of taken over that doesn't always get done. In particular, I think if there's not an immediate link on like a first try with a phone call kind of thing, we unfortunately are bound by health system requirements on text. We use a lot of um, communicating through the medical record for patients that allow like my chart communication and things like that. So yes, follow up to this is imperative, and I should have emphasized that more. By virtue of the fact that we're saying we can start medications without having these labs, there has to be a process in place to follow up on those labs and get people back in who may have lab abnormalities that should be addressed. Absolutely. Any data on the effectiveness of rapid start among trans women? So I do not have any data specifically with regard to trans women. I mean, in our population, I think the cohort that we looked at probably had about 1% trans women, but I have not seen any kind of outcomes data differing in those groups versus others yet. And I would imagine the numbers are small to date, but something to look at for sure. I think those were most of the
All right.
questions.
So remaining mindful of our time, we just want to thank you so much, Dr. Colasanti, for going through all those questions and being so generous with your time. And thank you to everyone who has who's logged in to view this presentation. We really appreciate all of you. So yeah, that wraps it up for today. And thank you once again to everybody for attending. And thank you so much, Dr. Colasanti. We really appreciate it.
Thanks, guys. That was a pleasure.